introduce Pam Macintyre too much. She is well known in the field, and she's of course one of the editors and co-author of the fourth edition or fifth edition of it's the fourth edition of the Stephans and hers and the Australian and New Zealand's evidence-based guidelines. So everybody knows you, and we are very excited that you are here. Thanks.
Thanks, Esther. And I have to say, I actually wasn't involved in the last edition of Scientific Evidence. No.
She's clever.
No. The second and the third did me in.
You have got your fourth edition of
Yes. Thank you very much. What I wanted to do, looking at opioid-induced ventilatory impairment this morning, is just quickly review the effects of opioids on ventilation, and then look at whether the reported incidence of OIVI or respiratory depression that is in the literature or in fact in big data actually accurate, whether it's worth trying to identify patients who are at higher risk of OIVI, has been suggested by many authors in the past, and what can be done to reduce the risk. So firstly, obviously the big concern that everyone has about opioids and safety is that excessive doses excessive doses will lead to hypoventilation, or can lead to hypoventilation, and high carbon dioxide levels in some patients. Usually when we talk about respiratory depression, we're actually talking, most people are referring to the effects of opioids on the respiratory centre in the brainstem. So they're talking about the effects of opioids on respiratory drive. And that in turn will lead to a reduction in either rate and or depth of breathing. Depression of respiratory drive becomes dangerous when the effects of opioids, the depressant effects of opioids, actually exceeds the stimulatory effects of high carbon dioxide levels and other stimulation effects such as pain. But there's other effects of opioids on the central nervous system. Firstly, like any sedative, they can reduce a patient's level of consciousness. And we know now that increasing sedation usually precedes the effect, obvious respiratory effects of opioids when patients have had an excessive dose. So it's the same effect as if the patient was given any sedative drug, not just opioid. And lastly, opioids we know reduce upper airway muscle tone. In particular, the tone of the genioglossus muscle, which is the primary airway dilator. So it can lead to, and it's usually when the patient is asleep, it can lead to collapse of the upper airway, either incomplete or partial, in which case the patient may snore. Either way, it's impairing gas exchange. So we're using the term now opioid-induced ventilatory impairment, or OIVI, more than respiratory depression, to try and get people to be more comfortable with the idea that it encompasses, opioid effects encompass more than just effects on the respiratory centre. So what's the incidence of OIVI? We've already had some information from the big data. Unfortunately, the measures that are used to determine incidence in both audits, randomised controlled trials, big data, may not all be valid. If they're not valid, the incidence that's been reported is inaccurate. And I think it's probably fair to say that we don't really have a very good idea of the risk that of patients developing OIVI. And it's because there's multiple definitions exist in the literature. The obvious one, or the best one, is a rise in the patient's carbon dioxide level. But for that, we'd need to do repeat blood gases or have CO2 monitors, which isn't going to happen for every patient. The carbon dioxide is a direct measure of the decreased ventilation caused by opioids. But other authors, and very commonly I think most people still use respiratory rate, which might be defined as less than 10 or less than 8 breaths a minute. Others will use oxygen saturation. Others still will use administration of naloxone, but that depends on the definition of OIVI in the first place. So it's not necessarily particularly helpful. One audit I came across looked at naloxone administration in the hospital, and interestingly quite a significant percentage of patients were given naloxone when they've never received an opioid. The measure that's not used very commonly in the literature yet, but was mentioned by the first speaker, is increasing sedation. And by that I mean an objective measure of a patient's sedation, not asking the patient how sleepy they feel, When they're too sleepy to talk is when we're interested, not that they feel a little bit lightheaded. And where sedation is used, there isn't an agreed scoring system. It should indicate a progressive decrease in the patient's level of consciousness, and not all scoring systems do. So CO2 is really the only accurate measures. All other measures that we use commonly are surrogate measures only, and at best they're only very loose indicators of OIVI and may not be accurate measures. And also, when they are used, there's a lack of standardisation in the literature, and certainly a lack of standardisation of threshold criteria. Who decides that a respiratory rate of less than 8 a minute is more appropriate than a respiratory rate of less than 10 a minute? And I think this was shown, and these are old data, but there was Cashman and Dolan back in the early 2000s collected information from all studies, not just randomised control studies, but audits and big cohort data that looked at pain relief and side effects from opioids administered intramuscularly by PCA or epidural analgesia. They collected a cohort, the overall cohort was about 20,000 patients. Of these, 165 papers looked at the incidence of OIVI and how OIVI was measured by those authors, or what determined the incidence of OIVI. And you can see, using respiratory rate of 8 to 10, it was reasonably low for all the modalities used, similarly for carbon dioxide levels. And I won't bother looking at naloxone. I think the standout here was hypoxia, when oxygen saturation was used to measure OIVI. And you can see that it was their data from this paper would suggest that those patients given intramuscular opioids had an almost 40% chance of developing OIVI. Clearly that's not the case in clinical practice, so there's something wrong with this measure. It's even more wrong when you look at their analgesic efficacy information in another paper they discovered, and combining both the moderate and severe pain scores after surgery. 96%, just over 96% of patients who were given intramuscular opioids had moderate to severe or severe pain. Clearly they did not have an opioid excess. They had an opioid deficit, if anything. So that oxygen saturation was not a good indicator. It way overestimated the risk of OIVI. This was shown also in a publication by Brian Reddy when they published on their results of the first year of their acute pain service in Seattle. And they noticed that there were 4 patients who were given epidural opioids postoperatively who developed OIVI. And you can see all in their 60s. All of them had high CO2s, 2 of them in mid-60s really, both who were markedly sedated, and 2 had very high CO2s, 95, 85 millimetres of mercury. Both of those patients were unconscious. The interesting bit comes, I think, if you look particularly at this patient, the patient who obviously by blood gas analysis had significant OIVI, never at any point when the observations were done had a respiratory rate of less than 12 per minute. Now admittedly, like in most hospitals, these observations were spot observations in the patients. It doesn't mean it didn't drop when the patient was slow, but this patient would not, in some studies, have been considered to have respiratory depression or OIVI, which I think is unsafe. Also, 3 patients did have supplemental oxygen. You can see 95, 99, 97%. It means that oximetry, particularly when the patients are getting supplemental oxygen, is not helpful. It will mask OIVI. But also the patient whose oxygen mask was not on had it still, with a CO2 of 95, had an oxygen saturation of 89%. So in some studies that use less than 80% of OIVI, she would again not have been counted of having respiratory depression. This was also found in a later study by Vila et al. They introduced a numerical pain treatment algorithm really as a result of accreditation requirements where pain needed to be assessed on a regular basis. And according to this algorithm, opioids were given if the pain, to maintain pain scores of less than 4. What they did, they improved pain relief, they also doubled the incidence of OIVI. And I'm just looking at the 29 patients both before and after the intervention. I'm not looking just at the after ones. I thought it was interesting that out of the 29 patients who developed OIVI, and some were very significant, they needed naloxone, intubation, intensive care admission, only 3 of those 29 patients had documented respiratory rates of less than 12 per minute. 27 of the 29 were noted to becoming increasingly somnolent prior to the event. So this showed not only that respiratory rate is not a reliable indicator of OIVI, which means unfortunately that most of the papers published using respiratory rate as an indicator are not giving an accurate assessment of of the incidence of OIVI, that titration of opioids to pain scores alone is neither sensible nor safe. And increasingly we tend to we use pain scores to track patients, but functional activity scores to titrate opioids. So coming back to one of the other topics I mentioned are some patients at risk of OIVI. There's a lot of patients that are said to be at risk, but I wanted to pick out one in particular, which has been a very popular topic over the years in the literature, and that's the idea that patients with obstructive sleep apnea are at higher risk of OIVI. This was first, one of the early alerts, I guess, appeared in the Anesthesia Patient Safety Foundation newsletter of 2002, where Anne Lofsky had reviewed claims from one medical defence company where there were a number of unexplained postoperative cardiopulmonary arrests in inpatients. When they looked at those patients, all of them had received an opioid, and all of them were thought to have a diagnosis of obstructive sleep apnea, sometimes post-event, not as a pre-existing comorbidity. From the 8 reviews, she then put together 2 composite cases to give an idea of the risk that patients with obstructive sleep apnea are at. The first one was a 45-year-old male, high BMI, relatively minor orthopaedic surgery under general anaesthesia, and the internist assessment preoperatively suggested this patient might have obstructive sleep apnea. 4 hours later, he was given 100 milligrams of pethidine, meperidine, 25 milligrams of promethazine, which was repeated 3 hours later. He died. He was found dead 2 hours later. This patient did not need to have sleep apnea to be at risk of respiratory depression. This patient was given opioid plus a very sedating antihistamine, not just once but twice. The second composite case was a 32-year-old male, fractured arm, again a relatively minor orthopaedic procedure under GA, and in retrospect the wife gave a history of heavy snoring and apnea, so the patient was thought to have pre-existing sleep apnea. For post-operative pain relief, he was given fentanyl PCA, 25 microgram bolus, 25 microgram an hour background infusion. He was heard to be snoring loudly, which some people think the patient has sleep apnea, so that's fine, that's their usual. And he was found in respiratory arrest 1 hour after his last normal vital signs. Again, I don't think this patient needed to have sleep apnea to be at risk. He was started on a PCA background infusion from the start, post-operatively, when we know that is a significant risk factor for OIVI. He was heard to be snoring loudly. That could have been the effect of opioids. It could have been the effect of an excessive dose of opioid. He needed to be checked, and he needed to have his levels of sedation checked, as well as we cannot rely on normal vital signs and presumably normal respiratory rate. And there's other similar cases. I just wanted to put up one more. This was a 45-year-old male, again a history suggestive of obstructive sleep apnea, again started with a PCA, with PCA morphine this time, a slightly higher bolus dose than most of us would start with, I guess, and a background infusion of 2 milligrams an hour. Snoring loudly, normal vital signs, found dead. These patients didn't need to have obstructive sleep apnea to come to harm. He had a PCA background infusion. He was heard to be snoring and his respiratory rate was fine. The monitoring was inadequate. He'd obviously had OIVI for quite some time. His PCO2 was 94, so that has taken many hours of hypoventilation to achieve. So I think, are there patient groups who are at risk? Absolutely, but I'm not sure that we can reliably pick out patient factors which put them at risk. We can reliably pick out factors that relate to us and the staffing on the wards. Firstly, poor prescribing with opioids and sedatives. Opioids alone, the way the PCA was ordered, or the addition of sedatives. Poor monitoring, and most importantly, inadequate response to early OIVI. And this was really confirmed in a publication last year, the beginning of last year, by Laurie Lee's group in Seattle, where they looked at, this is part of the ASA Closed Claims Analysis Project, and they looked at claims related, that is claims that are settled whether for the patient's family or not, or for the patient. And over a 20-year period, they identified 92 of these patients. In just over 3/4 of them, the patients either died or had significant hypoxic brain damage, so very bad outcomes. It's interesting that just over half under 50 years of age, nearly 2/3 were ASA 1 or 2, not groups of patients that we would consider usually to be at risk of respiratory depression or OIVI. 25% of them had or possibly had, in retrospect, a history of sleep apnea. I think most importantly, one of the very important messages was that 88% of these events occurred within the first 24 hours of starting opioids. So one of the danger periods, again, it's not the patient, it's the first 24 hours after they're started, before we know how much opioid that patient needs. Obviously, there's huge interpatient variability, and titration at this time is essential for safety. And 62% of them were noticed to be somnolent before the event, and there's case after case where somnolence is noted but nothing is done because the patient's respiratory rate is normal. Most of the patients had PCA or neuraxial opioids. Nearly half of them had opioids by one route. A third of them were given a non-opioid sedating drug. A third of them had more than one prescriber, prescribing either opioids or sedatives, and 46% had some kind of continuous infusion. These last four factors we know lead to an increased risk of OIVI. So again, it's the prescribing and monitoring needs to be thought about. So in this closed claims analysis showed firstly that younger and fitter patients are also at risk. We can't say they're more at risk because I suspect families and patients who are younger are more likely to sue. But nevertheless, young fit patients are at risk of OIVI. And they concluded that the vast majority of events occur, as I showed you, within the first 24 hours and are often preceded by a period of somnolence. Another review of 134 reports of OIVI in the literature by Overdyke also led to this conclusion, that despite the patients having some risk factors or some factors like sleep apnea or being elderly that would usually be considered to put them in increased of OIVI, in this series the majority of patients had no underlying risk factor that would knowingly put them at risk. So is it sensible to try and identify the at-risk patients? I don't think so. And Dan Sessler wrote this in an editorial accompanying another paper looking at postoperative hypoxia last year as well. And he said, while it's tempting to target continuous monitoring to high-risk patients, such as those with a history of sleep apnea, the best prediction system will only identify a fraction and probably only a small fraction of at-risk patients. So if we try and identify at-risk patients and use better monitoring for them, then we're actually putting a whole lot of other patients at increased risk. So, can we decrease the risk of OIVI? We may not know the true incidence. Can we decrease the risk? Well, even if we don't know the incidence, yes, of course, we need to decrease the risk. And there's a number of ways that Dan's already mentioned, which include avoiding opioids altogether. And I'm not sure I know we haven't got to that stage yet, especially for major surgery. But should we also be using multimodal analgesia and opioid-sparing techniques? And I think most of us would agree, and we would do that. We do need to improve, however, the recognition of OIVI in the first place, and we certainly need to improve the early response and management when we identify patients who are developing OIVI in the early stages. We do have to have much better opioid prescriptions. There are still some odd prescribing habits out there. And we need to titrate opioids, as I said, I don't think just to pain scores. I think that's asking for problems. Again, fine to track a patient's progress, but titrate according to function activity as well, and to sedation scoring. And we also need to avoid, obviously, the factors that increase the risk of OIVI. PCA background infusions used when the PCA first starts, addition of sedatives to patients who are finding it difficult to sleep. I just want to make a couple of comments very quickly about multimodal analgesia and opioid sparing, because it's obviously, we all think if we can reduce opioid dose, then we will automatically reduce the incidence of any opioid-related adverse effects. And with most of the techniques of multimodal analgesia, and I'm not looking at them individually, whether it's paracetamol, NSAIDs, ketamine, there is good evidence for many of them for a reduction in opioid dose. That is true. There's good evidence for some of them for a reduction in postoperative nausea and vomiting. There is very little evidence for a reduction in the incidence of OIVI. Now, it's partly because I don't think we're measuring it properly in the first place, but partly you'd need studies of thousands of patients to show a significant difference. But when we use opioid-sparing techniques, we need to not do the patient any further harm, primum non nocere. And pregabalin, I think, although it is a good way to reduce opioid requirements, it's a very good way to reduce the incidence of nausea and vomiting, it is also a very good way to increase the risk of sedation. And there are now case reports coming out about pregabalin added to an opioid regimen increasing the risk of OIVI. So I think we need to be a little bit careful in our quest for opioid sparing, that we're only doing good to the patient and not doing further harm. We need to improve detection of OIVI, as I said, and this is where it gets a little bit more difficult, at least for us, because we can't necessarily afford in our hospitals everything that would be suggested. Laurie Lee's group concluded that the majority of events were preventable, with improvements in assessment of the level of sedation, because remember nearly 2/3 were somnolent prior to the event, and also monitoring of oxygenation and ventilation. Ventilation is good. We'd need CO2 monitors. Oxygen saturation is really only measuring gas transfer across the tissues. So it's, as I said before, it's a very loose surrogate measure of OIVI. But she was saying we need to concentrate, especially in the first 24 hours. The Anaesthesia Patient Safety Foundation also recommends continuous oxygen saturation monitoring, notes quite correctly that intermittent spot checks are unreliable. The paper that Dan Sessler's editorial was accompanying was by Sun et al. That showed, I think, what we've all known for a quarter of a century: when you wake patients up, their oxygen saturation levels improve. So spot checks by the nurses waking them up gives you a false sense of security. They're recommending that if patients are getting supplemental oxygen, which most of our patients do, and in other hospitals, then that continuous CO2 monitoring should be used, but also that a patient's level of sedation should be monitored. And just this year, ECRI from the States suggested following APSF guidelines, which is terrific, on the continuous monitoring, and also recommending the use of tools such as sedation scale to assess patients' level of sedation, but not just to assess the level, to then use that to trigger an intervention. So if the patient is easy to wake, has trouble staying awake, then their opioid dose must be held and then reduced in future. The potential drawbacks from electronic monitoring that we would have in our hospital would be cost. There is probably no way I would be able to convince any of the administrators that every inpatient given an opioid needed a CO2 monitor. Even if we could do that, I'm not sure how we'd educate the staff or how we would have the settings, the threshold for alarms, so that we didn't get a lot of alarm fatigue. And my biggest concern, I think, if we concentrate solely on continuous monitoring, is what do we do when we send patients home? Many patients now go home after day surgery, for example. They may take their first dose of opioid at home. They might have a regional block that wears off 6 to 8 hours after they get home. So what about the patients at home? It's easy to teach them sedation scoring. So just to finish up, the effects of opioids and ventilation are more than a respiratory rate. We don't have, therefore, a very good idea of the incidence of OIVI yet after all this time. While some patients may be at higher risk, it's no point in picking out those you think will be high at risk, because it leaves other patients at risk. Opioid-sparing techniques are good, but they mustn't increase the risk. It's easy to introduce proper sedation scoring systems. It's easy to teach patients and their family sedation scores when they go home. It's probably difficult, certainly in our country, to mandate continuous opioid monitoring in all patients. Thank you. Get down.
Fantastic. I think what we might do is do questions at the end of the session, if that's okay, just kind of keep to time, if that's right. Good, thank you.